Welcome everyone to day 2 of the International Symposium on Malignant Mesothelioma. We're so excited to kick off our second day. IMEG, or the International Mesothelioma Interest Group, kicks off today across the street. IMEG is a global scientific conference that is dedicated to the study and treatment of mesothelioma. This conference brings together mesothelioma physicians and researchers from all over the world every 2 years. When we discovered it was going to be in Philadelphia, we planned our symposium to be here as well, so we could take advantage of some of the amazing presenters who would be at IMEG to speak to our community. Our first session of the day is one of those amazing presenters, Dr. Kevin Blyth. Dr. Blyth is a professor of respiratory medicine at the University of Glasgow in Scotland. He founded and is a director, of the Macmillan Scottish Mesothelioma Network, which coordinates clinical care and access to clinical trials for mesothelioma patients in Scotland. He's here to present on the future of imaging with AI, artificial intelligence. Welcome, Dr. Blyth.
Good morning, everyone. Thank you very much for that invitation. So it's a pleasure to be here. As you've heard, I'm a clinician, so I look after patients with mesothelioma in Glasgow, and I also run a national service for those patients across the country. And our research program has a broad range of topics, but one of the big ones is imaging and how we're using AI to kind of optimize the use of imaging. These are my disclosures. This is confusing because this isn't moving on in front of me. Okay, I'll work here. So what I'm going to try and do in the next 20 minutes or so is just cover some of the problems that we have in clinical care. And I suspect some of these will be familiar to all of you. And then I'll try and cover some solutions, some of the things that we've developed, AI technologies that can make life a bit easier. And then I'll finish with some challenges and some of the kind of problems that remain and actually making AI a kind of routine part of clinical care. So this image, I think, kind of illustrates one of the big reasons why we need artificial intelligence, particularly to interpret images in medicine. And that's because humans are quite variable. We see things in different ways, even on the same image. So some of you will see a young woman in that image, and some of you will see an old woman. And one or two of you might be able to see both. How many folk can see both? You're very special if you can see both. Yeah.
I see a woman, an elephant eating a woman.
Yeah. And you see an elephant. Well, that's very special. Yeah. You're making my point for me perfectly. So, but we see things in different ways, and that's a great superpower for humanity, but it's not helpful if we want consistency in reading things like CT scans and reading things like pathology and other things. A good example of that is the performance of radiologists when they look at a CT scan. So the image that you see there is a CT scan of a patient with early stage mesothelioma, and they have a pleural effusion, so this is the liver, and this is a fluid collection around the lung called a pleural effusion, and the disease is on the lining of the lung here, and you can't really see that. And it's very difficult for radiologists, and the sensitivity of a CT scan when a human reads it is about 60 to 70%. And there are 2 pretty large studies that show that, and that means that 4 out of every 10 patients has a CT scan that the report comes back and it says this is just fluid. There is no definite tumour here. when we take those patients to do a thoracoscopy, we can actually see that there's disease in the lining of the lung. So humans find that difficult to do. But the performance depends on which human reads the scan. So these numbers, these numbers here correspond to the sensitivity, so how good the radiologist is at picking up mesothelioma, depending on whether they happen to be an expert thoracic radiologist, so somebody who specialises in chest scans, or a general radiologist. So the individual human who reads your scan affects the result, basically. And that's not what we want if we want equity and we want a high performance across all patients. The other place that you see this variability is in the measurement of mesothelioma volume on a CT scan. So these are CT scans of a patient with mesothelioma, and in yellow, a radiologist has drawn round the areas that they think there is tumour. And that's how we can get a measurement of volume manually. And so you can get a number from that, and you can predict. This is a survival curve, so it's how long patients are living after having a scan. And the outcomes differ depending on the amount of tumour that's on the CT scan. But what is frustrating is that when a different radiologist looks at the same scan, they get a different number. And unfortunately, it doesn't present particularly well, but there are some red drawings here where that radiologist has drawn different areas of tumour. And so that, again, is a big challenge if we want to, even if we want to compare the amount of tumour that's on a CT scan before chemotherapy or after chemotherapy or before any intervention. So we measure response to treatment using criteria called modified RECIST, which is this M-RECIST. And what modified RECIST is trying to do is give us a measurement that reflects all of this red disease. And that's the whole volume of the pleural tumour that's visible. But at the moment, a human can't actually do that because they have to actually manually draw around every slice of a CT scan. And there are 200 slices on the average CT scan. So what we actually do is we ask our radiologists to just summarise what you can see. So just make some measurements at 2 positions on 3 slices of the 200 slices that are on the CT scan. And then you get these sorts of measurements, and then we ask the radiologist to then repeat those measurements on the next CT scan that the patient has after treatment. And these are all reasonable measurements that a radiologist might make. But if the radiologist chose those positions, and then when they look at the second CT scan, these are all, again, reasonable measurements that the radiologist could make on the second CT scan. So he or she has matched the position in the chest. But you can see, depending on which position, you get a different answer. Some of these, the disease is a bit thinner. Some of these, the disease is a bit thicker. Some of these, the disease is the same. And so actually we have a measurement for response that is quite inconsistent and quite difficult for human radiologists to measure. And again, that's a challenge and something that, as I'll cover, the AI can help us with. We have tried to quantify the amount of disagreement that radiologists have when they report CT scans. And so the numbers here correspond to a study that we ran in the UK, where we retrieved CT scans from 4 centres for about 200 patients. And we got CT images for about 170 of those patients. And we asked our expert radiologists, so we have 5 or 6 expert radiologists who run our national service. So they're used to looking at CT scans every day. And we asked them, 2 of them, to independently review the same scans and tell us what the response was on those scans. And the focus of the study was a genomic test that's not important for this discussion. But it was very sobering to see the amount of times they did not agree with each other. So in green, we're showing the amount of times that they agreed. So there's a response, and in both of these readings, there's stable disease in both of these readings. There's progressive disease in both of these readings. But you can see there are everything else, whether it's yellow or red, is a disagreement, which might be not a huge disagreement. It might be like in yellow, we've got where one person says it's response and the other person says, I think it's stable. But there actually are some where one person says there's response and someone else says there's progression. And so it's very difficult for humans to do this. And it's not because the radiologists are not good radiologists. It's just that mesothelioma is a very complex shape in the chest. It's not a nice round circle that you can just measure. So we need better tools. We need better ways of doing this that don't rely on humans reading pictures in a different way from each other. I don't want to get into this in huge amounts of detail, but this does have an impact on how effective we are at delivering clinical trials. Because when we do clinical trials, what we have to do at the moment is you have a treatment, and then you have your scans, and then your scans need to be read by a radiologist. And quite often, we might have 2 or maybe 3 radiologists reading the scans because we know that there is a level of inconsistency. So that adds cost. But the other issue is that if we do have the sorts of misclassifications that I showed on the previous scan, the trials that we design don't run as we expect them to. So there are certain characteristics of trials that are important. That one of those is power. So the power of a trial is the ability of that trial to read a true result if it's present. And we tend to power trials based on numbers of patients and various other things to give at least 80% power. And these graphs show some modelling studies that we've run, really plotting varying amounts of misclassification reading the scans against the actual power that the trial delivers. And so you can see there's an intended power here of 80%, which is the minimum we would usually have in a clinical trial. But if you have the sort of disagreement levels that we reported in that previous study, which was 35%, then the actual power of the trial drops dramatically. And so there's a bigger risk that we're missing real effects, or that we're reading effects that aren't actually there. And I won't go into the endpoint coverage, which is a similar issue, but is slightly more complex in terms of the stats. So what are the potential solutions? So I've kind of laid out some problems. So we're going to now try and talk about some solutions, which is the kind of positive part of the discussion. So there are solutions to some of these problems, and that's exciting. So I've kind of cut these up into detection, quantification, and response, which is the issues we've touched on. So detection, first of all. So we don't have very good AI tools yet for detection. And that is largely a reflection of the kinds of studies that have been published so far. There are some studies that show quite high accuracy of using computer methods which aren't quite artificial intelligence. This is machine learning, which is not quite artificial intelligence, where you can add features from a CT scan to other features of the patient, like their age and maybe their gender and maybe some symptoms, and you can build a classifier. You can build essentially a a model that will spit out an answer and say this patient is very likely to have mesothelioma or they're not. But the imaging that goes into that is still a radiologist saying there is pleural thickening here, there are pleural plaques here, there are these features. So it's not an automated AI read. And also most of these studies, the testing is being done in differentiating mesothelioma from patients who've got normal scans. But that's not real life, because that's not what happens. We don't ask the question in that setting. We don't do screening for mesothelioma in the general population. We need to detect mesothelioma on a scan when a patient comes in with symptoms. And their scan is usually abnormal for another reason. They've maybe got a fluid collection for another reason, like an infection, or maybe a different type of cancer. So we really need better studies that recruit those sorts of cohorts. We have done some work using MRI to try and do that. MRI has got some advantages over CT scanning. There are some practical benefits in that there isn't radiation and there's some other things, but you can also do perfusion MRI perfusion imaging, with MRI that's much harder to do with CT because of the radiation doses. And so we've published some studies that show that MRI is quite sensitive. The issue is that the analysis of the MRI by the radiologist, the perfusion data, is quite laborious and it's difficult. And if it's difficult and laborious, as we've discussed already, it will end up being inconsistent and it will not actually be deployable in routine care. So working with colleagues in Brazil, we have automated the reporting pipeline. And so I'm going to show you some images that show how that works. So this is an MRI scan, just to orientate you. So we've got the patient cut in an axial plane here, and then in a coronal and sagittal plane, so here and across here. And the first challenge with perfusion imaging is when you do perfusion imaging, you do a baseline scan, you inject some contrast, and then you have to repeat the scan to see how the contrast, the dye, washes into the pleura. So one of the big challenges is actually lining up the first scan with the second scan, with the third scan, with the fourth scan. And so the first challenge is to actually co-register all those scans on top of each other and then draw around the pleura. So you've got the pleura in a nice volume that you can take measurements in. So you can see here that we've drawn round the inside of the pleural space in yellow. And so really what you've got here is the fluid collection around the lung shown in a segmented volume. And then we then just grow that region out into the pleural space. And we've now got a nice segmented volume of the pleura. The next step then is to extract the perfusion features from inside the pleural tissue. And that is measuring how that contrast is washing through those regions. And so you can do that. These are called superspells, which are essentially regions of the pleura that are connected through time, through about 14.5 minutes. And you can see different regions of the pleura show up in different colours because the contrast is washing through them differently. And then we have to then apply some criteria to those contrast behaviours and pick out the regions that are having a very high, very quick wash-in of contrast that then washes out quickly, which is what mesothelioma looks like. And then you end up with a tiny number of these small regions which correspond to areas of mesothelioma tumour on the surface of the pleura. Because you may remember on the image of the thoracoscopy that we saw at the start, where the disease is on the surface of the pleura, It's not one tumour, it's not a blanket of tumour, it is little studs of disease that's on the surface. So that's a solution that is not in the clinic yet, but is showing some promise. PET scanning, as many of you know, is very commonly used in cancers of lots of different types. In mesothelioma, we don't use PET scan routinely as a diagnostic test, which is why this study, although it's helpful, probably doesn't advance the field hugely. So this study is reports the use of PET scanning as a diagnostic in a large retrospective cohort. And so the good thing here is that these patients are the right controls. These patients have benign pleural disease. These are not normal patients. So this is the right kind of study. AI, these numbers basically correspond to the higher this number is to 1, the better the decision that's being made by, in this case, the AI. So we have got reasonably high values here that suggest that deploying AI tools on PET scanning can be helpful. I think the biggest progress that we've made is in the measurement of tumour by volume, which is one of the problems obviously we talked about before. So we now 4 or 5 years ago published the first study, which is this study in 2021, reporting the performance of an AI trained to detect mesothelioma on CT scans. So what we did in the study is that I had a poor research fellow who sat in a dark room for 3 years, drawing round every slice of a CT scan, and he did that on 80 CT scans times 220 slices, which is a lot of slices, to train an AI. So this is one of his drawings, and this is an AI segmentation. And these figures really show that there's quite good correlation between what the AI reads and what the human reads. But the AI does make some mistakes. So these are CT scans, and this is one of Andrew's drawings. Andrew was a PhD student, and so Andrew has correctly drawn round the tumour, and he has included this little finger of tumour that goes into the fissure of the lung. But the AI has missed that. And same here. And this is one of Andrew's drawings. He's correctly segmented the disease over here, but the AI has thought there's maybe some disease over here, and that's because there's a small collection of fluid on the other side, which is benign. But AI will only learn with sufficient volume of information. So if you have in your training set not a lot of cases that have got these features, it won't have learned that that's the wrong thing to segment. So we needed to do another study to really increase the size of the training information that the AI was reading. And so you can now see, this is a study called MesoQ, where we've collected 2,000 CT scans from 1,000 patients across these centres in the UK. And this is another poor PhD student called Josh. Thankfully, Josh is a mathematician, so Josh doesn't need to draw around any CT scans. He just optimises the AI, and this is one of Josh's optimised AI reads. And we're using a process called active learning because you can't draw around 1,000 CT scans. You have to use a different technique. I won't go into a huge amount of detail in terms of the method, but essentially we have batches of 200 CT scans that have had the AI deployed on it and some segmentation performed. And then we have 6 clinical experts who score those reads. And if they're very good, those good reads get added back into the training set. If they're really bad, we get someone to draw around those scans again, and those re-annotated scans go back into the training set. And so we have cycles of training and annotation, and we can optimize the AI that way. And so this study, the primary endpoint, so the measure that would tell us the AI was good enough to use, was that when we got to the point where these 6 readers, 90% of the time said that the scan was good. And so this study met its primary endpoint recently, and so we're about to validate that in scans coming from here, in patients that have had an operation, where they have got a CT scan immediately before their operation. We can read the AI volume on the scan, and then we can compare that to the amount of tumour that the surgeon took out of the chest. And these are really the results of that analysis. And the detail's not hugely important, but essentially it's a rating score of 1 to 5, and if we had more than 90% of 1s and 2s, then we'd achieve what we were after. So there are still some challenges with AI, and this is a very nice example of AI will train only on what you present it. It has no context, so it has no general intelligence. So if you or I looked at that, even if you're not a doctor, you and I would know that that's COVID. Well, we'd know that's a cat. And we wouldn't confuse that with COVID. But this essentially is published a few years ago now, but this was an AI that was trained to detect COVID on chest x-rays. And then the research group showed it images of cats, and it said with very high confidence that that was COVID. And that's because it's not seeing a cat, it's seeing pixels, it's seeing grayscale, it has no context. And so one of the big challenges is unseen data. So we can have perfect studies, but then when we put the AI into the real world and it sees messy CT scans from emergency departments that haven't been perfectly acquired, then scans can, perform less well. AI tools can perform less well. And another example of context is the kind of hype around self-driving cars, which in very controlled environments perform well, but when you put those self-driving cars into messy environments like the real world, then they don't perform quite so well, and they crash. And so we need to learn how to use AI in the real world, and it's not a panacea. It will not devolve doctors of the responsibility to look at scans, and it's more about using AI than being replaced by AI. And the other issue is actually understanding uncertainty. So when a doctor or anyone looks at a scan, then they usually, if you read a doctor's report, usually the longer this report is, the more uncertain the doctor is about the actual outcome. So we very rarely write reports that says this is definitely this is definitely that. But actually, when we interpret AI literature, we almost expect the AI to say it is or it isn't, and that's not really realistic. So we need to be able to understand and quantify uncertainty in using AI. So these images, for example, an AI I think all of us could say that over here that's a dog, and over here that's a skier, and maybe over here that's a building. That does get quite hard. But actually, these graphs, the detail's not important, but the performance of the AI in terms of its confidence dramatically falls off when you just have a slightly messy image. And images are messy in real life. And so we need to train our doctors to use AI and be able to express uncertainty and understand uncertainty. And we're not quite there yet. And the last slide here really is just a challenge around access to data. So we've got all the computing power that we need to do AI studies. The big challenge is connecting that infrastructure and that computing power with the large volumes of data that exist in healthcare providers, be that in the NHS or be that in hospitals. And actually, there's a tension there between natural and really important privacy concerns and the fact that most of the state-of-the-art practitioners are in industry. And so using things like, at the bottom here, we've got a schematic of a trusted research environment, which is a secure, firewalled space that AI researchers can interact with scans, but they can't extract data and they can train models. That's a big challenge. And so the last slide is actually making AI explainable. I think there is a challenge. I think the methods that AI uses to learn are opaque, and there is a kind of perception that it's a black box, and to some extent it is a black box. And actually, voices like yours in terms of helping AI researchers explain and design studies so that we can embed very transparent methods is really important, because it's quite hard if you come to clinic and you're told your treatment's stopping because the AI said it should. Well, how did the AI make the decision? So we need to do a good job of making those methods transparent and understandable. So I'll finish there, and we have made some progress with some of these problems, but AI is not perfect, and as I say, it won't replace doctors. It's more about supporting doctors to make better decisions. So thank you very much for listening.
For one or two quick questions.
Have you done any of the same kind of analysis with peritoneal scans?
We haven't, but I think the same challenge it's exactly the same challenge. It's difficult. It's coating surfaces, and it's maybe even a harder challenge actually. And because the numbers of patients are smaller and you need volume to train, then I think for that we would definitely need large collaborative studies.
This is all very, very fascinating to me in the way it's, we've talked about AI for a long time, but in the past few years, how it's just really exploded. So my protocol has always been MRIs, and I know that's maybe next on the horizon as far as reading images with AI, but is that something that has been talked about, or is that a possible trial that's coming up?
Yeah, so I agree. I share your kind of I preference for MRI. We've got a big part of our program's MRI. MRI was my postgraduate degree, so I would love to see us use it more. The problem in training AI tools and actually deploying those is that so few clinicians use it. So few radiologists use it, and the CT remains the workhorse. And until we can collect better evidence that shows a real meaningful benefit to MRI, and we can convince our radiology colleagues to use it and buy scanners and things, then I think it's quite difficult to see it having a big role.
You said that you're having a problem getting readings, getting scans to experiment with. What I kind of got from that because of the hospital firewall.
Yeah.
So my question is, if we, for example, wanted to voluntarily submit our scans and see what AI could tell us with them, is there an opportunity for us to do that?
I don't think so directly. I think we have now got at least two big projects that have been really successful in bringing it together sufficient numbers of a sufficient number of scans to do the training. I think the next step probably for the segmentation work is probably to deploy those tools alongside human readings in clinical trials and see if we can actually make the argument that we can replace the current human methods. But there isn't a way that we can take scans in directly.
Julie, if you find out a way to get AI for us, will you tell us?